All right, everyone, welcome back to the deep dive.
Yeah, thanks for having me.
Really glad to have you on. We're going to tackle some seriously tough FRCS material today.
Absolutely. And it's something that, I see residents struggling with all the time, and that's carpal injuries.
Right, and especially those fractured dislocations,
Mhm.
they can be a real nightmare on the exam.
Oh, they're definitely a high yield topic. And the thing is, you really got to understand carpal mechanics and anatomy.
For sure. So
Nice.
let's just dive right in, starting with these greater arc injuries. Um, the source we're looking at here emphasizes that the force travels along this greater arc. It tends to break bones rather than just tearing ligaments.
Yeah, that's right. It's about the path of least resistance. I always tell my residents that bone, especially that scaphoid bone, it can be weaker than the ligaments around it.
Well, that's interesting. Okay.
So when you have this strong force moving along that arc, the scaphoid kind of gives way
Like
first.
a chain reaction, sort of.
Exactly. You get the scaphoid fracture, then the lunate pops out of place, and then sometimes even more fractures.
Wow. So how do we even begin to name these injuries? I mean, it sounds like there are so many different variations.
Well, we always start with peri-lunate dislocation because the lunate's that key bone that's dislocating, right?
Okay.
Then you just tack on the other fractures involved. So like you said, transscaphoid peri-lunate dislocation. That means the scaphoid's fractured and the lunate's out of place.
And this is the most common one,
Right.
right? According to our source here.
Yeah, that's the one you'll see most often.
Now, there's also that transcaphoid, transcapitate, peri-lunate dislocation. I mean, that sounds like a mouthful.
It's a tough one, too, because the capitate can actually rotate.
Yeah, the source says almost 180 degrees. I mean, why is that rotation such a big deal?
Well, think about it. That rotation, it basically locks the wrist in this deformed position.
Oh, okay.
You can't just pop the bones back in place like you would with a simple dislocation. You're fighting against that rotational force.
So you have to go in surgically.
Often, yeah, open reduction's usually the way to go.
That makes sense. And in general, is treatment for these greater arc injuries,
Mm-hmm.
I mean, is it kind of similar to the lesser arc injuries?
In a way, yes, both often require open reduction and internal fixation.
Okay.
But greater arc injuries, well, they can be more extensive. You might have multiple fractures, ligament tears, that capitate rotation we talked about.
Right.
Plus, the risk of complications like arthritis is higher.
Makes sense. All right, so let's shift gears a bit to axial fracture dislocations. I mean, these sound pretty intense.
Oh, they are high impact, for sure. Imagine like a really heavy object just crushing the hand.
Okay.
That force literally splits the carpus lengthwise.
Longitudinally.
Yeah, one part stays with the radius, the other gets pushed out either towards the thumb or the pinky side.
Okay, so that's where all these subtypes come in, right? Like
Yeah.
the source talks about axial-radial and axial-ulnar, each with even more subtypes like paratrapezoid or transtrapezial.
Mm.
Do we really need to memorize every single one for the FRCS?
It's not about just memorizing, it's about understanding the anatomy. The key is to focus on the subtypes that really matter clinically.
Hmm.
The ones involving the scaphoid or the lunate, those have a bigger impact on how the wrist works.
Right, right.
Like if you have a scaphoid fracture on top of an axial injury, that makes things a lot more complicated.
I can imagine. And the source also stresses the soft tissue injuries that come along with these axial fracture dislocations. What should we be looking out for?
Yeah, those are crucial. You can have damage to blood vessels, nerves like the median or the ulnar nerve, even tendons that control the fingers.
So it's not just about fixing the bone.
Exactly. You can do a perfect job putting the bones back together, but if a tendon's messed up, the hand won't work right.
Wow, so you have to assess everything really carefully.
Absolutely. And your surgical approach has to address both the fractures and the soft tissue damage.
So often it's a combined approach then.
Right. You might go in from the back of the hand to fix the fractures, then go in from the palm side to repair tendons or nerves.
I see. Okay. And last but not least, we have those isolated carpal dislocations. These seem pretty rare compared to the other patterns we've talked about.
Yeah, you're right. They're not as common. They usually happen from a direct blow to one specific carpal bone. It just gets knocked out of place.
So what about treatment? I mean, the source mentions a few options.
It really depends on which bone is dislocated and how far out of place it is. Sometimes you can try to pop it back in, but that often doesn't work.
Okay.
If it's really unstable, you'll need open reduction and internal fixation. And sometimes if the blood supply to the bone's been cut off, you might just have to take the bone out altogether.
Wow. Okay, so to sum it all up for our FRCS prep, we need to be able to tell these different carpal injury patterns apart, understand the forces involved, and look at both the bones and the soft tissues.
Absolutely. And always think about the biomechanics. How does the injury affect the way the wrist moves? How will your treatment bring back stability and function?
Great advice. Any final thoughts for our listeners?
I'd say think about how those different forces, we talked about how they influence your treatment choices. Like,
Hmm.
Would you approach a greater arc injury the same way you'd approach an axial one?
Hmm, that's a good one. All right, that's all the time we have for today's deep dive. Thanks for joining us, and we'll see you next time.
Thanks for having me.
Take care.
All right.